All right, everyone. Welcome to Department of Medicine Grand Rounds. Dr. Dent, we're going to get started. Is now okay? All right. Well, thank you all for joining us today. We are very excited to welcome one of our very own faculty members, Alex Dent, to present to us today. And Alex, if you want to go ahead and share your slides. And for those that are just joining the CME code, I'll put it back in the chat again, but it's 18860. And Alex Dent is going to be presenting transfusion medicine updates to us. He is an assistant professor in the Department of Pathology and the medical director of the blood banks at Emory University Hospital Midtown and Winship at Emory Midtown. And he has been with Emory since residency, having completed fellowships in both transfusion medicine and medical microbiology. He is a prominent presenter at national and international meetings, has authored numerous book chapters and peer review articles, and so he is extremely qualified to educate us on old and new updates in transfusion medicine. In advance, he wants us all to know he is very sorry that we do not have an unlimited supply of platelets, but has left plenty of time for Q&A for other questions at the end of his presentation. With that, thank you so much, Alex, for joining us. I'm going to hand the mic over to you.
Well, thank you very much. Thank you all so much for the opportunity to talk to you. I think the joke about pathologists, like how can you know if a pathologist is outgoing? It's if they look at your shoes instead of their own when they're talking to you. Um, I just want to reassure you that I love talking to people. I'm very honored to have the, opportunity to talk to you all. I want to hear, what frustrates you about the blood bank, and I've tried to incorporate things in my talk that have come up as I've been on service as a trainee and as a faculty member, common sources of confusion, misunderstanding. We exist, to help you treat your patients effectively and appropriately. But we are a medical subspecialty on our own, and we do have expertise that we're more than happy to share with you. Um, so I will go ahead and get started by telling you a little something old and new about myself. And that is, let me struggle with the pointer. Let me get this to go away. It's distracting. I have to hide my self view. Otherwise, I'll just be like staring at my shrinking hairline the entire time. So let's see. Is this working now? Yes. Okay. So something old and something new about me. So the irony here is that the new picture is what is the old me. So this is a new picture of a bunch of architecture models stacked up in an architecture firm where I used to work as an architect. The old picture that's on the right is of a man named George Judson, who is sitting at one of the first apheresis instruments. So George Judson was an engineer at IBM, and his son Tom was diagnosed with acute leukemia in the early 1960s. His son Tom was treated at the NIH with this newfangled thing called combination chemotherapy by none other than Emil Freireich. And his son was also getting apheresis, but at the time it was a discontinuous manual process where they would draw 2 units of blood from a patient if their blood volume would allow. They would spin them down in a bedside bucket centrifuge, pull out the white cells, the buffy coat that had the acute blasts in it, and retransfuse the remainder of the blood back into the patient. And he saw how inefficient that process was. And he talked with Emil Freireich and had a working prototype of a continuous flow apheresis device within 6 months. And it's essentially still the basis of what we do today. And even though it's an old picture, it represents the new me. So now I work primarily in the blood bank and in micro. And so when I say old and new, I'm not trying to be pejorative. I'm trying to talk about things that are foundational, not necessarily things that are outdated, but also inform you guys about recent changes or relatively newer thoughts that are informing transfusion medicine. So our objectives for today are generic enough to give us lots of flexibility to talk about things. We're going to talk about the presenting symptoms of transfusion reactions and what we do within the black box of the laboratory when you trigger a transfusion reaction evaluation. I'm going to use this as an opportunity to talk about some updates in transfusion guidelines, specifically for red cells. We're going to talk about how we look at apheresis indications and what the different methodologies of sorry, there's a rapid response, and talk about what the indications for how we think about apheresis indications. It's more than just plex. There's actually a guidelines published every 3 or so years from the American Society for Apheresis, or ASPA, and it includes 166 indications for apheresis. Then we're going to talk about the blood products we stock and what we can do to those blood products. So these are common product modifications as well as newer technologies that are alternatives to some of them. The spoiler alert for that part of the talk is that we do not like to make unnecessary product modifications. They only make blood products better for select subsets of patients, and they have consequences that makes the blood products worse for other patients that don't need those product modifications. So let's jump right in. And this is the foundational thinking of transfusion reactions. This is, what everybody knows. If you're contacted about a transfusion reaction, the most important thing is to stop the transfusion. The nursing will notify you guys about about what's going on with the patient. They should also be notifying the blood bank, and that will trigger an order of a transfusion reaction evaluation within Epic. And this is where I would like to point out that transfusion reactions are relatively common, specifically the non-infectious complications of transfusion. So you can see that a febrile non-hemolytic transfusion reaction, and I know it's a mouthful, but I'm going to try to say it that way every single time, because what distinguishes a febrile non-hemolytic transfusion reaction, which is one of the most common transfusion reactions that occurs from an acute hemolytic transfusion reactions, is the presence of hemolysis. And so a lot of the symptoms overlap between a very common, very boring transfusion reaction and a very serious, potentially fatal transfusion reaction. So I will try to say febrile non-hemolytic transfusion reaction every single time, but I might get slightly tongue twisted. And when I counsel patients and consent them for blood transfusion, this is what I say. I say, your body is more likely to recognize some part of the blood as foreign and have an immune reaction to that blood product than you are to get an infection from that blood product. As proof, here is what we think of currently as being the risk of infection through blood products, and you can see these are in the millions. But you'll recognize there's some organisms here that we do not test every blood unit for, which we'll talk about in a little bit. So one of my messages to you guys is what keeps our blood safe is the donor health questionnaire that the questions we ask donors at the time of donation, not necessarily the testing that we do, because we're only testing for 8 specific organisms when we are testing donor blood, but there's many more things that can be transmitted through transfusion. And it really is a donor health questionnaire that is keeping the blood supply safe. So, but you're not going to be really, you may be asked about this when we do look backs, because every time a donor comes to donate blood, if we see that they have, HIV, we do a look back for the past year, and we say, okay, they've donated this blood in the past year. Even though they tested negative for HIV at the time, we're going to reach out to those patients and ask that they ask them to have a conversation with their physician about whether or not they should be tested. What you're going to get asked about, though, is when the nurse sees a fever, when a nurse sees that a patient has respiratory distress during transfusion. And so if you haven't heard much about transfusion reactions before, you're about to hear about them a lot more frequently, because CMS came to visit EUH last week and audited our nursing transfusion policy against our transfusion practice, and found several instances where patients had fevers during transfusion, but and some of those were patients that came in with fever. Some of them had hypertension, even though the patient had underlying hypertension. But because our policy was relatively ambiguous and broadly written, we were not following our policy. And so we are working to revise those policies. I think we were doing right by our patients, because, in instances where the symptom of a potential transfusion reaction was recognized, nurses were reaching out to the patient's physician or provider and having a conversation with them, but our nursing policy read slightly differently. And So we're working on reevaluating that. But one of the things we recognized was that we are required and have not been providing annual education to providers about the signs and symptoms of transfusion reactions. So get ready for some mandatory education about transfusion reactions. I suspect it will look very similar to this. Um, but fever is is something that can exist in patients regardless of whether or not they're being transfused. So it doesn't necessarily indicate that they're having a transfusion reaction. However, fever can be the presenting symptom of an acute hemolytic transfusion reaction, which is obviously a very severe transfusion reaction. It's important to have a index of suspicion for reactions to transfusion if they occur. And I see a comment, so I'm going to chat. So let me see what that says really quickly. Oh no, I hit the wrong button.
Carlos is
Can
asking
that,
if, yeah, can the
oh,
10 rounds count as our training for the
that's a
updated transfusion module that you'll be
that's a
probably rolling
great
out?
question. I suspect we will submit it to CMS as a in our allegation of compliance, but that is not my decision, so I can't promise one way or the other. Um, Patients can also have shaking chills during transfusion. If your patient is getting granulocytes, and I hope they aren't, but if they are, you should know that rigor is an expected consequence of giving someone a bag full of active neutrophils. But that's an aside. Respiratory distress. So this, we've defined this in our new policy. We will define this more closely. One thing that I will talk about in a minute is the difference between TACO and TRALI. One thing I've seen commonly on service is that, someone has radiographic changes after transfusion and the thoughts jumps more quickly to TRALI than TACO, but in my experience, it's more commonly TACO than TRALI. So we'll talk about the difference between those two. Um, then we have these symptoms of an allergic transfusion reaction, pruritus, hives, new rash, swelling, or flushing. If your patient only has symptoms of a mild allergic reaction, it is safe to restart that transfusion. However, in the future, you may be asked by a nurse to put in a nursing communication order and or a brief note that says, I was contacted about a patient with these symptoms. The patient has been itching their entire admission. I believe it's safe to continue transfusion. More to come on that. It is not my decision. Vomiting can be a sign of a transfusion reaction, and it can occur in delayed transfusion reactions after the fact. We have defined hypotension. The biggest reaction that I'm concerned about when I hear that a patient has significant hypotension outside of apheresis is that your patient is having a septic transfusion reaction. If someone's getting apheresis and they're on an ACE inhibitor, we'll talk about the complication of profound hypotension that can occur in those patients due to the accumulation of bradykinins. Back pain or a sense of impending doom are kind of classic concerning symptoms of an acute hemolytic transfusion reaction. And finally, there's, you may want or you may be asked to check out the patient's urine after transfusion to see if they have increasing signs or symptoms of hemolysis. Most symptoms occur within 4 hours of transfusion, but transfusion reactions can be acute or delayed, and they can be febrile or non-febrile. These are general categories. These are not absolute. So you'll see TACO is included in the non-febrile transfusion reactions, which is usually true. But if you're using fever alone to distinguish TACO from TRALI, you can be led astray. So we know from the work of Alyssa Zyman and others that we have previously under-recognized how frequently TACO occurs with fever. Delayed hemolytic transfusion reactions, which is one of the delayed febrile reactions, is something I worry about a lot, especially in our sickle cell patients, because the symptoms of a delayed hemolytic transfusion reaction and the symptoms of a vaso-occlusive crisis are like circles. They're not Venn diagrams. There's so much overlap. It could be very challenging to parse those two out. And it was a case of a delayed hemolytic transfusion reaction that got me interested in pursuing transfusion medicine as a career. It was a third-year hemonc fellow who called our apheresis service and asked us to set up red cell exchange. And as she's talking about the patient, it became more and more clear that they were having a DHTR and a delayed hemolytic transfusion reaction. And I realized that if a third-year hemonc fellow cannot recognize it, that there's not much hope for people that outside of just how challenging it is, I think is the kindest way I can say it, because it is very challenging. I think we in the lab have a lot of perspective afforded to us by being slightly removed, so people aren't throwing bedpans at us and like yelling about drugs. So sometimes it's easier for us to have a different perspective into what's going on with your patient. So now let's talk about, what's changing, what's new, what were the new thoughts, and that is that the process is changing at AUH because of a CMS deficiency that we expect to receive within the next week. And we will have 10 days from the time we receive that to respond to it. But again, I just mentioned that as an aside. It's not critical for you guys to know that right now. But you should make sure that the nurses pause the transfusion. Why? So if someone is having an acute hemolytic transfusion reaction, the biggest predictor in outcomes of acute hemolytic transfusion reactions is how much incompatible blood that patient received. So stop the transfusion if you think they might have a transfusion reaction going on. Let's say that you're not sure what to think of the symptomology. You can call your blood bank and ask to be connected to the transfusion service physician. We are on call 24/7, 365. We'll talk about specifically the sites that are covered by the CTCT, which is the Center for Transfusion and Cellular Therapy, which covers EUH, EUHM, and Grady. We'll talk about that in the next slide. But if you determine that a patient is likely having a transfusion reaction, we will not restart that blood without talking to you first. That doesn't mean that your patient doesn't need blood, because we know that blood is a life-saving therapy in patients, even regardless of whether or not they're having a transfusion reaction. But you should anticipate a call from the transfusion service if you are asking to resume transfusion in a patient that is undergoing transfusion reaction evaluation. Okay, so these are the sites that are covered by the Center for Transfusion and Cellular Therapy. So EUH, EUHM, and WEM, Grady, sort of CHOA, the Hugh Spalding Clinic through the Grady Blood Bank, as well as the Ortho and Spine Hospital. We do not cover St. Joe's, Johns Creek, Decatur, or the other CHOA sites. Those are staffed by other pathologists, and they have their own blood banks that may advise you differently than we do, right? Sometimes we're contacted by the select specialty group, but our residents cannot make clinical recommendations on appropriate products for those. So we instruct our residents to call and talk to our pathologists at Grady that have the credentials to do that. So what happens next? So the blood bank will reach out to the transfusion medicine resident on call, and they will look at the significant findings. They may call and ask you, hey, has the patient gotten better? Is their PDARC? Is their respiratory status improved? It's really helpful to us. If you're collaborative with us, we're not trying to delay you getting your appropriate blood product. We're trying to quickly categorize their transfusion reaction to make sure it's safe. And like I said, we will not be issuing blood the blood bank will not issue blood without our approval. And if you need blood, expect to have a conversation with us. And you can reach out to us in the interim and say, look, this patient had a transfusion reaction, but I know they still need blood for their exchange transfusion or whatever. Reach out to us. We're happy to help. We will evaluate the transfusion reaction and categorize it and document it in the chart. So what is the blood bank doing while all this occurs? And I think of it as a few things that we're trying to do very quickly. We're trying to determine if hemolysis is a component of the patient's transfusion reaction, because the faster that we can exclude hemolysis, the earlier we can say, okay, it's safe for this patient to continue getting blood. We do visual checks of the post-transfusion sample, so it's important to get that sample to us as quickly as possible. And I want to remind everyone that a DAT does not automatically mean that a patient is having hemolysis. In this context, it's certainly more concerning, but your patient may have had a previous positive DAT. Your patient may not have a previous DAT. So this may be something that we've newly detected, but that something is not truly new in your patient. Um, the other thing I would mention is that just because the DAT is negative does not mean that your patient is not having hemolysis. If your patient has gotten incompatible blood and has hemolyzed all of the red cells that have that target antigen on the surface of the red cell, your DAT will be negative, but your patient is still having hemolysis. Um, the other thing that we're going to do with that post-transfusion sample is determine if a clerical error has occurred. Um, so clerical errors are still a leading cause of acute hemolytic transfusion reactions. It's one of the reasons why we are so strict about the labeling standards of specimens to the blood bank. We're not doing it just to be annoying. We're doing it because we know we decrease the incidence of errors the stricter our labeling standards are. We still do occasionally see wrong blood in tube. Every time we do, we file a safe report so that the feedback gets back to the appropriate person. We're more likely to pick it up in the blood bank because, if someone's blood type changes and they haven't had a bone marrow transplant, that's an indication that we are collecting the blood from the wrong patient. So the other thing we're going to do is we're going to determine if a new antibody is developing or has developed. Maybe the patient had an old antibody and has had an amnestic response to that. So as everyone who's gotten a COVID vaccine knows that your degree of antibodies typically wane, especially to some of the minor RBC antigens. So the kid blood group is a good example of this. And a patient can come back and their antibody level can be below the limit of detection for our antibody screen. But when we re-expose that patient to blood that contains the KIT antibody, their memory B cells are like, wait, I've seen this before. They kick into gear, start spitting out a ton of antibodies, and they have a delayed hemolytic transfusion reaction. And it's something we really worry about in our sickle cell patients, which is why sickle cell patients are put on sickle cell protocols where we're prophylactically matching them for
Yeah,
antigens.
yeah.
I'm sorry, someone's not muted, and I don't know if it's a question or if it's an accident. Okay, I hope it's an accident. Okay, so yes, so DHTRs happen because although our tests are very sensitive, it takes a certain degree of antibody for us to be able to detect it because we were using agglutination-based methods in our blood bank, like everyone else. And antibodies go away. And so we have to have a high index of suspicion for DHTRs. I think they're vastly under-recognized in all sickle cell patients across all institutions, including ours. What the resident is doing when we get the results of the serologic workup from the blood bank and the symptoms from the clinical team is we're working to categorize it. I've showing you the NHSN hemovigilance module, and this is the case definition and severity and imputability for febrile non-hemolytic transfusion reactions. And you can see that anyone who has fever during or within 4 hours of transfusion qualifies as having a febrile non-hemolytic transfusion reaction. Everyone can get this. This is super common, but fever can also be the presenting symptom of something that's super uncommon and super bad, which is an acute hemolytic transfusion reaction. One thing we do to reduce the incidence of febrile non-hemolytic transfusion reactions is we pre-storage leukoreduce all of the RBCs. You do not have to ask us to for leukoreduced RBCs. All of the RBCs that we stock in our hospitals are leukoreduced. So before I mentioned a little bit about the difference between TACO and TRALI. So now let's go on a little bit of a deeper dive between the two. TACO is fundamentally a plumbing problem, and TRALI is fundamentally an inflammatory problem. So TACO occurs in people who are predisposed to being volume overloaded or being able to poorly tolerate shifts in volume. And so it's cardiogenic pulmonary edema. These patients can have, radiographic changes, and sometimes we underappreciate the volume of fluids that we're transfusing patients when we're giving them repeated transfusion of RBCs or plasma. TACO is again, all of the transfusion reactions are under-recognized, but especially TACO, it is the leading cause of transfusion-related mortality today. TRALI used to be the leading cause of transfusion-related mortality, and it's fundamentally an inflammatory problem where the first hit is actually the patient's underlying condition. And so what happens in the lung is that the capillaries are super duper small, and neutrophils, in order to get through the capillary bed of the lung, have to distend. They have to be a little flexible. But in patients that have underlying inflammation, their neutrophils are in a state where they're not activated, but they are primed. This makes their membranes more rigid, and it prolongs the amount of time that those neutrophils are in contact with the endothelial cells and the lung capillaries. That changes the expression of adhesion molecules on those neutrophils, and it makes it more likely that neutrophils will diapedese into the alveolar space. And that all happens before transfusion. What happens with transfusion is that we are transfusing antibodies, typically HLA or HNA antibodies, that are capable of activating those neutrophils that are now hanging out in the alveolar space. That results in a surge of pulmonary edema, and it's non-cardiogenic pulmonary edema. And, I think one of the reasons why TRALI is no longer the leading cause of transfusion-related mortality is that we've changed our definitions of TACO and TRALI, and we're now recognizing more cases of TACO, and we're recognizing more less severe cases of TRALI. TRALI does have implications for donors. So if we will test that blood donor to see if they have HLA or HNA antibodies and exclude them from donation if they are present. So that's why it's really important that the people that are getting blood are the people that actually need blood. So this is something new. These are the most up-to-date guidelines for red blood cell transfusion published by the AABB about a year ago in October of 2023. So although it's new, it doesn't really change much because, it's the language in the article is that it continues to recommend a restrictive transfusion strategy for most adult and pediatric patients using a hemoglobin threshold of 7 grams per deciliter. It also emphasizes that the decision to transfuse should not be made based solely on a single laboratory value, and that the risks and benefits of transfusion to the patient as a whole should be considered. There is some weird language related to cardiac patients in these guidelines because these guidelines were published before this. This is MENT, which was a randomized control trial that specifically looked at restrictive or liberal transfusion strategies, meaning a hemoglobin threshold of 7 or hemoglobin threshold of 10 in patients with acute MI. We call this the MET, so myocardial infarction and transfusion. And the primary outcome of the study was looking at myocardial reinfarction or death at 30 days. And there was not a statistically significant difference, but that really buries the value of the study, because if you look at the other outcomes, what you will see is that a lot of the outcomes, virtually all of them, favored a liberal transfusion strategy. There was a fragility analysis done after the fact that said that 2 patients had had a different outcome. This would have reached statistical significance and favored liberal transfusion. But of course, what should have happened, could have happened, would have happened, didn't happen. And the only outcomes that were better under a restrictive transfusion strategy have to do with heart failure, probably because of the volume that patients get with additional transfusion, and pulmonary embolism or DVT, which probably has to do with changes in blood viscosity related to blood transfusion. But all of the other outcomes, and there's even a longer list if you look at the complete article, favored a liberal transfusion strategy. And so when you're deciding to transfuse your patients, it's going to ask you why you're transfusing them, right? And in case you weren't aware, the work of our Blood Stewardship Committee is actually keeping track of whether or not those indications are true. So This is a Power BI dashboard that is not ready for wide dissemination just yet. We're working on refining the informatics side of it to make sure this is as reliable as possible. The pathology department has lost one of our transfusion medicine attendings that was also an informatician, which has delayed this, unfortunately. But one of the things I want to point out is that this is looking at, let me get my laser pointer going. This is showing you the order reasons for transfusion. You can see that over half of the units transfused in our system are indicated. The indication listed at the time of order is a hemoglobin less than 7 grams. But what this chart shows is that that's not always true. You can see this year, there's been, in the first half of this year, there's a decrease in how often that was untrue from 16% of the time to about 10% of the time in all instances, which is a good thing. But we know that there are other indications for transfusion, and we're working to exclude groups where it doesn't make sense to only look at that. So, but the reason that you select for transfusion is not meaningless. I also want to point out that our system in the first 6 months of this year transfused 27,000 units of RBCs. We use a lot of blood. One of the things that uses a lot of blood is the massive transfusion protocol. So if you're not familiar with this, this is based on the proper trial, which dealt with the ratio of plasma to RBC to platelets in trauma situations. It was originally came out of the military, but now it's been applied to surgical and even non-surgical patients in hospitals. And so our protocols are good. They include the appropriate amount of RBCs to platelets to plasma. So if your patient is undergoing MTP, you should not have to ask for additional products unless your patient has something else going on. If there's some other evidence on something like thromboelastography that they need additional, products because of their alpha angle, whatever, we can talk about it. One thing that the proper trial did not address, but that we know from subsequent studies called Cryostat and Cryostat 2, is the importance of early administration of cryoprecipitate in trauma patients. And I think sometimes when I see a transfusion strategy in a patient where we're just trying to get to a certain platelet count, that we're not considering the other ingredients that patients need to make a clot, and an important one is fibrinogen. They also need stuff that's in plasma. Now, plasma will not correct minor abnormalities in the patient's INR. If their INR is less than 1.85, you're not going to improve it with plasma transfusion because plasma is anticoagulated. We have to anticoagulate plasma so that it doesn't clot when it's on the shelf. But if you're confused about MTP, we are releasing a fixed ratio of product. You do not have to ask or specify what products you want during an MTP. You will not get products faster through an MTP than you would with an emergency release order if you just need a couple of units of RBCs. And this is activated by an electronic order and a call to the blood bank. And please call the blood bank as soon as it is appropriate to terminate the MTP. The blood bank is in a holding pattern with the rest of its routine work as long as an MTP is going on, because our priority becomes providing blood for these patients. So when it's appropriate to discontinue the MTP, we ask that you do and inform the blood bank. So now let's jump to our second objective and talk a little bit about apheresis. So this is the cover page of the 2023 ASFA guidelines, and it includes a table like this. So you can see the disease or condition, the indication, the procedure. So you can see TPE, which is therapeutic plasma exchange, IA, which is immunoabsorption. You can also see there's also RCE and ECP. We'll talk about that in a minute. The category, which is whether or not this is appropriate first-line therapy. For category 1, it's appropriate first-line treatment with or without other therapeutic interventions. Category 2 means it's generally appropriate. 3 means that it should be the decision-making should be individualized, so we're not automatically going to do it or refuse to do it. Category 4 means we should not be doing apheresis for this indication. The grade is the evidence, it's how much evidence do we have behind this recommendation? And for a lot of these, you see that they're like 2C, 2B, which means it's not great. And I want to point out that apheresis isn't just plex. So the apheresis modalities that we have available to us involve centrifugation. And so this is the continuous flow apheresis device that George Judson came up with in the 1960s. We also have membrane-based apheresis devices that is kind of like hemodialysis. And then we have photopheresis, which is not something we do acutely but it's something we do in our outpatient apheresis clinic where we remove the patient's buffy coat. We treat them with a photoactive compound. We then expose that buffy coat to UVA light and we reinfuse those back into the patient. We don't fully understand the mechanism of how that helps patients, but it can help patients that are having cellular rejection of certain allografts. So this is the dumb way to remember the different, or I shouldn't say dumb. This is how I think of them. If you're getting, plasma exchange, red cell exchange, or platelet pheresis, it's also how we collect platelets at our blood donor. It's just a centrifuge. If you're getting LDL pheresis, so these are people with familial hypercholesterolemia, it's a membrane-based filter. The filter happens to be made out of dextran, and the positively charged lipoprotein moieties are sticking to those dextrans, to the dextran being pulled out of the patient's blood. And then we have extracorporeal photopheresis, which is, I think of it as baking autoreactive T cells in a tanning bed. So this is an image from a horror movie where I think they trapped some poor woman in a tanning bed and cranked it up. Okay, and so within the ASPA guidelines, when we look at each indication, and you're welcome to look at these yourself, it's going to talk about the category, the grade, and it's going to go through the rationale for using therapeutic apheresis to treat the patient, as well as technical notes, including what we're going to use as a replacement fluid. I will tell you that just because you order plasma exchange does not mean that we will use plasma as a replacement fluid. We do for certain indications, but we don't routinely like to use plasma as a replacement fluid for all indications because there's a lot of infectious complications from plasma. It's more expensive and it takes longer. So we only use plasma when there's a benefit to using plasma. When you call us to initiate apheresis, we'll ask you a few things. So if you want to help us, you can start thinking about these before you reach out to us. One is the vascular access. Are we going to be able to perform our procedure? We can perform some of our procedures using peripheral access, and our nurses can do a vein assessment if necessary. We're going to ask if your patient's on an ACE inhibitor because patients that are getting ACE inhibitors and plasmapheresis, they can, because of the exposure of their blood to the non-physiologic surface with the tubing within the apheresis device, they can get a massive accumulation of bradykinins and have really profound life-threatening hypotension during the procedure. So it's fine to use an ARB, but we cannot use an ACE inhibitor if we're using albumin as a replacement fluid, and we would prefer, if at all possible, to wait until the patient has been off of an ACE inhibitor for 48 hours or at least 24 hours. But we'll talk about that on individual patient-by-patient basis. We'll also ask you about consent because our residents are based at EUH, but they are covering the apheresis services at other sites as well. So we can help coordinate at EUH, EUHM, and Grady. The primary service provider changes based on what site you are. Some sites have secondary service providers and some do not. So we cannot help you with stem cell orders. And please, we ask that you be understanding of our staffing shortages when they occur. And weekend treatments take a little bit of extra coordination. So reach out to us if you anticipate starting someone over the weekend. Those 4 p.m. Friday consults get us every time, especially if the patient's been sitting in the hospital for like a whole week. And it's like, oh, we could have done it Thursday, but I think we all probably experience that to some degree. So what do we say when we consent patients? We explain to them that their blood will pass through a machine that will remove the part of their blood that is contributing to their symptoms. We say you will lose fluid because we throw away the entire compartment of blood, whether it's RBCs in the case of red cell exchange or plasma in the case of plasma exchange, and we replace that fluid with RBCs or plasma or albumin, depending on the disease indication. The common side effects that we always mention to patients are dizziness due to low blood pressure, numbness and tingling caused by low calcium. So we have to anticoagulate the patient's blood as it leaves their body and goes into the instrument. We use ACD. Yes, there is a shortage that you may have heard about recently. Um, and the patients, when we return their blood to them, we are exposing them to a little bit more citrate than they otherwise would. Patients that have normally functioning parathyroids typically return to normal calcium levels within 15 minutes. But when patients start having symptoms of hypocalcemia, we slow our procedure. We can give them extra calcium. We actually run calcium during our procedure to avoid this happening anyway, but sometimes patients do need extra calcium. This happens with apheresis blood donors as well. So for those of you that remember Melanie Wooten, when she would donate blood, she used to drink a milkshake on the way to get a little extra calcium. Most patients say that the procedure makes them sleepy because, especially if we're giving plasma, we'll be giving them antihistamines that will make them a little sleepy. Okay. I also reassure patients that a nurse specializing in the procedure will be beside them, monitoring them the entire time for signs and symptoms of a transfusion reaction. There are some things that other things you should expect to occur during plasmapheresis, because although we think of, our blood as being neatly separated based on, the density of that particular compartment of their blood, in reality, it's a little blurry. And we're also looking at a very small section of the overall blood column. So if your patient's getting plasmapheresis, you should expect their platelet count to go down. It will recover within 48 hours if the cause of their thrombocytopenia is apheresis. If their platelet count hasn't recovered after 48 hours of discontinuing apheresis, you should look for other causes of platelet refractoriness. The most common causes of platelet refractoriness are consumptive, and even in patients who have evidence of immune-mediated platelet refractoriness, when we give them specialized product, whether that's cross-matched or HLA matched product, they don't respond to that product either. And it's like only 24% of patients with evidence of immune-mediated platelet refractoriness respond to appropriately selected product. We can talk more about that later. So our last section I'm going to get through quickly, so we have time for questions, and that is to talk about some of the product modifications and alternatives to them. So we only stock leukoreduced RBCs, and we only stock pathogen inactivated platelets. If you haven't heard of pathogen inactivation, go away. If you haven't heard of pathogen inactivation, we'll talk about it in a minute. We stock all kinds of plasma, but you don't have to worry about it. There's all kinds of weird and quirky rules about what we call plasma based on when it's collected, when it's processed, and when it's thawed. That comes from the history of plasma being used as a replacement for hemophilia patients. So it matters the degree of activity of the heat labile transfusion factors, so factors 5 and factors 8, are influenced by how long you wait to freeze the plasma and how long it's been since you've thawed the plasma. So when you order plasma, you may be getting FFP, you may be getting something called thawed plasma, you may be getting liquid plasma, maybe getting PF24, you may be getting all kinds of things. And unless you're using plasma to treat hemophilia, you don't have to worry about it. We only stock one kind of cryoprecipitate. So most of the time, there's not much to select, but we can modify our RBC blood products. Again, you don't have to ask for leukoreduction. We leukoreduce all our products before we store it to decrease febrile non-hemolytic transfusion reactions. It is considered equivalent to collecting blood from CMV seronegative donors. So this is why you will hear leukoreduced blood called CMV safe blood, not CMV negative. Irradiation only does one thing, and that is it prevents transfusion-associated graft versus host disease. And so we only like to do it for patients that are at increased risk of having transfusion-associated graft versus host disease. We'll talk about those patients in a minute, but the But by exposing all of the red cells to, that irradiation, we're prematurely aging the unit because we're damaging the RBC membranes. It also shortens the expiration of the unit. So we do not like to do it unless there's an indication. Same thing for washing. Washing only prevents recurrent, severe to anaphylactic transfusion reactions. This is classically in IgA deficient patients, but just having IgA deficiency is not enough to warrant product washing. We look for patients that are known to be IgA deficient and have a history of anaphylactic transfusion reactions. The consequence of washing for, patients that don't need it is that it decreases the hematocrit by up to 20% in red cell units. It decreases the platelet count and platelet activity of platelet units. It shortens the expiration. Washing systems are all open systems, meaning that we are introducing the possibility of contamination. So we do not like to do these product modifications unless it's necessary. Let's talk about pathogen inactivation before we talk about radiation and graft versus host disease. So I want to point out that pathogen-reduced plasma and RBCs are not currently available, but that all of our platelets are pathogen-reduced. So what we do is we treat the platelets after they've been collected with a photoactive compound, amotosalen here. It's a sorolin compound. It situates itself between DNA base pairs, and then we expose it to UVA. It forms these adducts such that this nucleic acid is glued to each other and they cannot replicate. And when you think about nucleic acids inside a platelet unit or an RBC unit, RBCs and platelets do not have nuclei. Yes, in the bone marrow, their precursor cells do, but most of the nucleic acids that are in a unit of RBCs or in a unit of platelets are contaminants, either from white cells or from pathogens. So this technology is called pathogen inactivation, but the product is called pathogen reduced. And pathogen inactivation is considered equivalent to irradiation. Remember that irradiation is just damaging the nucleic acids so that those immune competent cells cannot replicate. And that's exactly what pathogen inactivation does. And in case you aren't familiar with graft versus host disease, we have to talk a little bit about the HLA system, talk about how this occurs. And this is a classic setup for transfusion transmitted graft versus host disease, which is almost uniformly fatal. So here we have a recipient who is heterozygous at a made-up HLA loci, where the donor is homozygous. So, our HLA system is how our body distinguishes self from non-self. So the recipient is looking at the donor and it's saying, oh, this is me. This is, HLA-A2. But the donor is looking at the recipient and saying, this is not me. And so if this recipient is someone who has impaired T-cell mediated immunity, if they're, an intrauterine, if it's a fetus getting an intrauterine transfusion, if it is a patient that has a hematologic malignancy, if it is a bone marrow transplant patient, those are all indications for irradiated product. Having HIV, having solid organ transplant, having a solid organ cancer are not typically indications for irradiation. But again, pathogen inactivation is considered equivalent to irradiation. So if you're worried about platelets, you shouldn't be, because all of the platelets that we're providing our patients are treated with pathogen inactivation. Okay, we have 10 minutes left. Because I have an interest in micro, I'll just tell you that the history of transfusion medicine has really been shaped by infectious disease. And the movement toward pathogen inactivation is really a change in the paradigm of how we think about mitigating that risk. So based on an outbreak of syphilis, syphilis in the 1950s, post-transfusion hepatitis in the 1960s and 70s, and HIV in the 80s, those have had huge consequences on our donor testing and our donor deferral. In case you aren't familiar, last year, after 40 years, the FDA lifted its ban on men who have sex with men from being able to donate blood, because they realized that they could ask questions to ascertain which subset of men who have sex with men are at higher risk of transmitting HIV through transfusion. Some folks think that the current guidelines do not go far enough for men who have sex with men that are on PrEP. The reason that men on PrEP are excluded from donating is because it prolongs the window period for HIV, meaning that these patients can be infected with HIV, but we will not be able to detect it with our most sensitive tests. This is my last slide. I would not be a good transfusion medicine attending if I did not ask you to please give blood. Give blood for me. I can't give blood. It used to be because I date a man, but now it's because I'm on a medications. So please give blood. We're approaching a time of the year where we expect there to be a blood shortage, which is a winter recess. So if kids are out of school, you should expect that the blood supply will be slightly more constrained than usual. The Red Cross sent out an email from their chief medical officer yesterday, reassuring us that it looks like our blood supply is strong going into this winter recess. But if influenza cases start to increase, I would expect to have a blood shortage within a few weeks of us seeing that increase. Um, Thank you very much, and I'm happy to answer any questions that I can. Okay, I just rambled a lot.
Thank you so much for this. Carlos, I just saw you come online. Do you something you want a question or a
I
comment?
was I was going to say thank you, Alex. This was great. It's such a important topic for us to know. And I mean, all of us have been called because a patient developed fever after a transfusion, and I think it's really important to know what to do, what can you do, and David Alter just put in the chat the question: at what point do you give acetaminophen, Benadryl? What's the management you do, and what's the advice that we should have as internists when we're called to see that patient with a febrile, with a quote unquote transfusion reaction?
Yeah, so you will routinely tell us in patients that have, febrile non-hemolytic transfusion reactions, please consider, pre-medication with acetaminophen prior to transfusion. There is, I'm going to say no evidence. That's controversial, but that's my opinion. There's no evidence that actually prevents fever in patients that are receiving transfusion. I think we do it to make ourselves feel better and to make our patients feel better. There might be a value in doing that and saying, we're giving you this because you had that. But there's not convincing evidence to me that it's actually helping.
I mean,
Same thing with
I
diphen.
may be wrong, but I think all of us, when we order a transfusion, we routinely give acetaminophen and do these things prophylactically. But it may not be. It may just be voodoo more than anything else.
Yeah. Yeah, same thing with diphenhydramine. Like, if someone has a mild allergic reaction, we'll say, pre-treat with diphenhydramine, but there's no great evidence that that's actually preventing mild allergic reactions in those patients. So I see something. Was there
There are
not?
a couple
Let's
of really
see.
good questions in the chat, Karen.
We have a couple of really great detail questions. I'd love to
Okay.
ask a broader question for our general medicine group because I think it's always so great when we have specialists like yourself come to talk to us. We put a face to a name. There is like hopefully less activation energy to calling and connecting on cases. So my first question is really about, when you talked about transfusion reactions and when we choose to stop the transfusion, and really gave us a window into what your team is doing behind the scenes once we do that. Can you give us a bit more guidance on when it might be appropriate to call you? When we decide to stop the transfusion, would that be an appropriate time to call to say, hey, I think I'm stopping this transfusion. Can I just talk through some of this with you? Or when do you guys like to be called and involved in that process?
Oh gosh, that's a thorny question because some pathologists it might be never. No, but we're always happy if the guidance that I give, especially like trainees, is if the thought enters your head, should I? Go ahead and do it. Like, we're always happy to talk through what may be going on. You know, um, Especially if you're wanting to resume transfusion, right? So you recognize that this could potentially be a reaction, but it's still important to continue transfusion because the patient's having an acute chest and we have to finish the exchange transfusion, right? We don't want to waste these units, especially if it's a rare unit of blood. One thing I should have mentioned is that if you were called by a transfusion provider and said, hey, we found a frozen unit, do you want it? What we are asking is, are you going to transfuse this unit? That is because we cannot ask the rare donor program to thaw that unit and send it to us unless we know we're going to transfuse it. So we can't get that unit just in case. Frozen units are stored in glycerol and they have to be washed before they're sent to us. That's not something we can do in-house. And we keep Frozen blood we save for 10 years, but the reality is we're not going to throw it away after 10 years. So we have transfused blood was as old as 37 years, and that's an extremely rare unit, right? Just because your patient has a fever and they've been in the hospital with fever, that doesn't mean that we should stop giving them this precious resource, especially if they have something underlying. So if you're in a situation where something doesn't make sense that the blood bank is doing, or you have an urgent transfusion need and what you're talking to the blood bank on the phone, it's not making sense, please reach out to us. We want to help.
I think that's so helpful, especially because, again, you're such a specialty consultative service. I think we all know when we are considering apheresis, we have to talk to your team. But it sounds, this presentation has really helped me to think about how we can leverage your expertise in so many of those other sort of like shoulder periods where we're thinking, should we not? Let me just get my friendly transfusion medicine team on the phone. So then follow-up practical question about that. You gave us numbers on a slide, but if we just call the operator, is there a sort of, can we just say, can I have the transfusion medicine team paged? I have a question. Or when we're looking for you sort of at the point of care, what's the best way to find the right person?
Yes. So if you were at Grady, Midtown, or EUH, it's actually the same PIC number for the on-call transfusion medicine resident, and that is 50346. I will drop that in the chat. And the residents that are on right now are going to be killing me, but sorry, it's our job. So that is the PIC number that will reach you. We're on call 24/7, 365. They have backup
Awesome.
from a fellow and an attending.
Thank you. Thank you so much. So we have a couple of detailed questions, some great questions from John Davis. Was there or was there not a recent change to donor screening guidelines about screening of multiparous patients to reduce TRALI cases?
Yes, so it depends on the blood supplier. And so that is not something that we decide on our transfusion service, but something that the Red Cross, Life South, Vitalant, something that they've decided about implementing screening procedures for multiparous females. So I'm not the best person to speak to those, but your recollection is correct.
Okay. And then the current infusion consent is very generic. Is there a role for it being renewed to reflect more actual risks without totally freaking out patients?
Oh gosh, that's a tough question. One thing that I will share with you guys, but that I do not routinely share with patients, is that we don't know. We say the risk of HIV transmission through transfusion is about 1 in 2 million. We transfuse about 2 million units of blood products each year. So you would think that each year we're detecting about 6 cases of HIV. In reality, we don't know of a case of transfusion transmitted HIV since 2008.
Mm.
So we have transfused over 100 million units of blood products during that time. Now, there's lots of caveats to that. Not all the people that receive blood live long enough to develop the symptoms of HIV. Some people don't follow up. Sometimes we don't catch the yada, yada, yada. But it's very, very rare. And it's so low that we don't use clinical observations to talk about those risks. We talk about the incidence of HIV in blood donors and the window period of the organism to calculate those. So it's really nuanced. I always try to be reassuring to patients that your immune system is more likely to recognize something in this transfusion as foreign and react to it than you are to get a transfusion transmitted infection.
Yeah. Um, is there a carcinogenic risk to a patient who's receiving platelets from the agent inactivating pathogen DNA?
So not that I'm aware of, not that I don't believe that, not that anyone else is aware of. We have seen that there are more instances of platelet refractory patients that are getting these pathogen inactivated platelets, probably because their immune system's getting slightly irritated by the residual amount of amotosalen. We essentially put an amotosalen sponge in the product to soak up all that sorlin compound after we've treated it with light, but there still is a small amount in
Thank
the
you.
product.
And then a clarification question. Did you say that some DHTRs can be DAT negative?
Yes. So if a patient has, every test has, sensitivity and specificity that is not perfect. And if your patient has, if your patient has hemolyzed all of the RBCs that have the target antigen on it, then the DAT would be negative because there's no red cells with that antigen on it for our DAT to detect. So I think of DAT as the directly attached test. It tells you what is on those RBCs, not what's floating in the patient's serum. That's the IAT or the screen, right? And so if the DAT is negative, that doesn't mean that your patient isn't having hemolysis, but it also doesn't mean that your patient is having hemolysis.
Got it. And that might be a situation where we might just consult our friendly transfusion team just to talk through some of the possibilities if we're trying to figure that part out.
Yeah,
Okay. And
we're
then,
happy to. And if the DAT is positive in a patient that's having a DHGR, we can do an elution, which is where we knock off the antibodies that are coating that RBC and try to see if it has any specificity. Unfortunately, in a third of DHTRs, we never identify an antibody specificity.
okay. And then last question, because we're at 102, but I see the resident rooms are still on, and this is a great question from Dr. Kobayatse for the residents and for all of our hospital medicine physicians. Um, can you do Plex through a really good IV, or do we really have to have a central line in place?
Yeah, so you need a dual lumen port because it has to be able to tolerate the flow volumes that are very fast, and it has to have a staggered port so that we're not creating a futile cycle within the patient and immediately withdrawing what we're transfusing because it is continuous flow. So we are pulling and pushing at the same time. Now, in your sickle cell patients, like you have to have a certain hematocrit to be able to undergo red cell exchange. So if your patient's hematocrit is below, below 22% or 20, depending on the institution and the instrument you're using, we're going to have to get to that hematocrit with simple transfusion before we do an exchange transfusion because those patients cannot tolerate having the amount of blood in the instrument that needs to be in the instrument. The extracorporeal volume of the instrument is too high for those patients.
Gotcha. Okay. I know that that's always a common question when we consult you for Plex or apheresis of some sort is do they have the appropriate access in place? Alex, thank you so much for joining us today and sharing your expertise with us. Very illuminating. Thank you for all of the information, and we will all be much better about consulting our friendly transfusion medicine team when questions arise, in addition to all of our consultative needs for apheresis and other things. Thank you so much.
Well, thank you all very much. I'm happy to have spoke chatted. Thanks.
Have a great day, everyone.